morning, good afternoon, good evening. I'm Dr. Tanvir. I'm a practicing consultant at Tanvir Hospital, which is located in Hyderabad, India. I'm a gynecologist by profession, an OBGYN, and my area of interest or my area of practice is minimally invasive surgery. So I'm a certified endoscopic or hysteroscopic surgeon. I'm also a clinical fellow of urogynecology, and I've done my advanced training in minimally invasive surgery. I practice at Tanvir Hospital, where we have an Advance Gynecological Center. You can go and check the website Advance Gynecological Center for all the details. I practice with my senior, Dr. Meeta, who's also a practicing gynecologist and an obstetrician, and Dr. Akanshi, who's our obstetrician and a gynecologist. So we cater to women who have problems of abnormal uterine bleeding, of infertility, polycystic ovarian disease, menopause, and osteoporosis. We also cater to women who have urinary problems or pelvic organ prolapses. So my area of interest, as I've mentioned, is in these fields, and I also perform advanced ultrasounds. Recently, I have completed my training from Harvard in clinical research, and the reason for doing that is because clinical research, if done in the right manner, has very good clinical application to improve patient care. That is the main reason to perform research, and that's exactly what we believe in, to give the best to our women. Hello, good afternoon, good morning, or good evening, wherever you are placed. I'm Dr. Tanvir, and I'm going to talk today about how hysteroscopy could be useful and can be useful in infertile women or in treating infertility. Let us talk about how hysteroscopy can improve pregnancy outcomes or conception outcomes in women who are infertile. What is the first question which I very commonly been asked? What is hysteroscopy and how is it useful in infertility? Hysteroscopy is a method of putting a small thin camera through a tube, with a tube, into the uterine cavity. As you can see here, this is the uterus with the tubes and ovaries. So from the place where a woman bleeds, we put in a small camera attached to a tube which goes inside the cervical canal through the internal passage inside, looking inside the uterine cavity. Now this cavity is very important, and the innermost lining of the cavity is extremely important for pregnancy. That is what we look at. This is where the child is, the baby is. And that is how the baby is born from here. So the hysteroscopy is mainly used to look at the uterine cavity, the endometrium, the most important area, so that pregnancy success is good. How is hysteroscopy useful in diagnosing infertility? Infertility is a problem where a man and a woman, after having unprotected intercourse for 1 year, cannot conceive. Or any woman who is older than 30 or 35 years, at least a minimum of 6 months. That is when we call infertile couple. So many a times, some common structural problems persist inside the endometrium. And these problems can cause infertility. They are very much treatable, and they can lead to natural conception if the egg quality is good and the sperm quality is good. So that when we perform a hysteroscopy, these structural problems, when I say structural problems, these are problems which may cause heavy bleeding and which may cause pain, which may cause disturbance in the menstrual cycles. Also infertility. They are fibroids, they are polyps, or they can sometimes be septums, or now very commonly we find dysmorphic uterus. That is, the cavity, the shape of the uterus is different. It is not very normal. So these are the problems that can be diagnosed while performing a hysteroscopy, and they also can be treated with hysteroscopy. And to tell you, a transvaginal ultrasound has a very good accuracy of almost around 80 to 100%, 98 to 100% to diagnose these problems. So somewhere around 80% to around 98% to diagnose problems inside the endometrium lining, such as polyps, fibroids, or any of these conditions, uterine conditions. Whereas hysteroscopy has equivalent to 100% accuracy in diagnosing problems because you're seeing directly under vision. So basically, when you perform a hysteroscopy, you see a big TV, just like you do an endoscopy, very similar to that. You see the uterine lining and the problems on a big TV which has a 20x magnification. So it is magnified by 20 times. That's why the subtle lesions are also very commonly diagnosed with hysteroscopy. How does hysteroscopy improve the conception rates? Does it improve the conception rates? Yes, it does. The conception rates have found to be improved by almost 60% after performing a hysteroscopy in women who have a polyp or even a fibroid. So what do? We remove the polyp and we remove the fibroid, and that hence leads to an improved conception rate and improved take-home baby rates. So that is what it can do. So, and this can happen after removing. So the timeline, when we talk about the timelines after this, it's usually 1 year. And how long do you wait after the procedure to start planning for pregnancy in a natural way? Here we're talking only about the natural way. So you can wait anyway between 2 weeks to 1 month to 3 months, depending upon the pathology or the problem that we have treated using a hysteroscopy. That your doctor will let you know depending on what problem you've had. What conditions causing infertility can be treated by hysteroscopy? So I've already told you a few. The first one, I will start with lower down. Sometimes you do find infections that can be seen on the naked eye that we perform while doing a pelvic examination. After that, when we proceed with a hysteroscope, we do sometimes find endometriotic lesions inside the vagina, deep inside the vagina, which can be missed while performing a pelvic examination. So that itself, helps in diagnosing women with a problem which is otherwise undiagnosed. Then, in the cervix, that is, the cervix sometimes is closed, and this cervical canal which is closed is called stenosis. This can be treated using a hysteroscope. The next step that can be diagnosed and treated is a polyp, as you find here. This is an endometrial polyp. So this polyp is nothing but an overgrowth of the endometrium, and that also can be treated, diagnosed and treated in the same sitting with hysteroscopy. A fibroid, which is a mass, which is not cancer. So, but it is a mass of the muscle. This particular fibroid or tumor of the muscle, this fibroid can also sometimes be present inside the uterine cavity, and it can be treated by the similar manner. The other things that you could find are subtle lesions. Subtle lesions are also present, which I will touch a little while later. Septum, that is a congenital problem. Talking about it, this is what a septum would look like, which is called a thin layer or a fibrous layer in the uterine lining. Women are born with these conditions. These can sometimes cause problem in getting pregnant, or sometimes these conditions make women have abortions. So we perform something called a septal resection, which is done with a hysteroscope. So the whole septum is cut and the uterine cavity is made with good space. So it could be a complete septum, it could be a partial septum. There are also other conditions where you might have a double uterus or a double uterus along with a septum. Now, this can also be treated, most of it could be treated with hysteroscopy. So, these are the many conditions that we can treat. There are some conditions which are subtle, which I was talking about. So, you must be coming across, there are women who come to us who say they have been having repeated abortions. They've been tested extensively, they've performed an ultrasound, an endometrial biopsy, a blind endometrial biopsy has been done, and they get a lot of battery of blood tests done, repeated ultrasounds, examinations, repeated trial to get pregnant, loads and loads of medication, but yet failure. They don't get pregnant or there are repeated abortions. In these women, it would be ideal or it is important to complete with a hysteroscopy. And we have found something called subtle lesions. Subtle lesions are something which are not really very symptomatic sometimes. They do not appear on ultrasound every time. So the diagnostic criteria can be very challenging. So because hysteroscopy is the magnification which we see of the endometrium, we find some like an infection, like a micropolyps or inflammation inside the uterine cavity. Now this inflammation can be treated with certain antibiotics and certain medications. Also adenomyosis. So when we say adenomyosis is nothing but it is blood or endometriotic lesions inside the muscle. That is the endometrial glands. The endometrium goes into the muscle and that is what causes adenomyosis. This condition also can be diagnosed and to some extent it's possible to treat hysteroscopically. Or if you diagnose it, it is possible to treat it with medication leading to success of pregnancy. Why these lesions, the subtle lesions, cause problem? So when we say inflammation, so what happens is there is a layer between the muscle and the lining. Now this layer is very important for the movement of the sperm and also for implantation of the baby, of the fetus. That is, once a mother gets pregnant, it is important that the baby that is growing inside the uterus is implanted. Now, this junctional zone, we call it a junctional zone. That is a zone in between the endometrium and the muscle. It's very important for pregnancy and for implantation. If that zone has problems such as inflammation, so there are some bad cells going on there or bad stress going in that junctional zone, or there is blood or there is endometrial glands or there is sometimes the fibroids, the polyp or infections, these all cause problems in getting pregnant. So when you diagnose them and treat them correctly, the success of pregnancy is higher. So the prevalence of these problems in infertile women with even failed IVFs is almost around 23 to 25%, which is quite high, which goes undiagnosed because many a times hysteroscopy is surpassed and IVF is planned directly after having failed inductions or unable to get pregnant naturally. So that is the importance of performing a hysteroscopy in selected patients, which especially IVF is being planned. So the next thing I want to talk about is, and also many of these abnormalities, the diagnostic, the presence of these abnormalities, all the abnormalities that I've mentioned, be it a fibroid, be it a polyp, the subtle lesions, adenomyosis, septum, which is missed on ultrasound and diagnosed on hysteroscopy, is almost 30 to 45%. So it can be missed on an ultrasound, especially if it is being performed by an inexperienced radiologist or a sonologist who does not have a knowledge of the endometrium. So, an important tip is if you're getting an ultrasound done, also get a transvaginal ultrasound. Do ask for a transvaginal ultrasound. So, going to our next question. We're talking so much about hysteroscopy, we're talking so much about infertility, right? So, how is hysteroscopy performed? Can it be performed in the outpatient, that is without anesthesia? Yes, it can be. There are different kinds of hysteroscopy that can be performed as in different settings. First, we can do it in the inpatient settings with admission where we keep you in the hospital sometimes for 24 hours. And the second type is where we keep you just as a daycare, admit in the morning and you can go back home by night. The other method of doing it is an outpatient method or an office method, sometimes in where you don't even have to change your dress. You walk in, 1 hour, you're in the hospital, the procedure takes about 10 to 15 minutes, and then you can head back home. When we perform outpatient hysteroscopy, it is done without the use of any anesthesia or minimal anesthesia. And most women are quite happy with the procedure. So 98% of the procedures can be performed in office or outpatient. That is, without the use of any anesthesia. So basically, there is no IV line either. We don't give you an injection. We don't give you anything. Well, is it painful or not? Well, I'm sure that's a major question which is being asked, or most women ask. The first thing they ask me is it going to be painful? And I understand the concern because I'm going to do something in a very private area without giving them anesthesia and they're awake. So it's a compromised, in a compromised way, but without compromising the surgery, of course. So when we talk about this, why doesn't, well, what happens? Does it really pain? We compare it to something called menstrual pain. So when you have your menstrual periods, this hysteroscopy for some women is as equivalent to the menstrual pain, a normal menstrual pain, or absolutely no pain. They feel a pressure in the lower abdomen because we put in some normal saline, that is water. We put inside and then we look at the cavity. So we distend the uterine cavity, which is collapsed together. And we look at it with this magnification and with minimum or no pain or discomfort. So hysteroscopy is not always painful. Most of the times, no, if performed correctly by an experienced surgeon. It is not painful. So 80% of my practice is in office, that is without anesthesia. And we do all the operative work in office. The advantages of office being that the cost comes down by almost 40% to 50%. The woman can get back to her daily activities sometimes the same day or the next day. And there is no stress of being in the hospital. So those are the advantages of performing in-office hysteroscopy. There are pain methods or pain controlling methods that we use in office, which we will discuss with you, or the doctor that you're seeing will discuss with you when you are undergoing an in-office hysteroscopy. So the other thing that I also want to talk about is how long does it take to recover after a hysteroscopy procedure? In-office hysteroscopy is immediately. If we admit you and if we have to put you under complete anesthesia, it can range from 1 day, the same day, or to the next day, or about 2 to 3 days. And what you need to do, or what care you need to do after performing a hysteroscopy, you will have minimal bleeding. There will be some bleeding. You must avoid sexual intercourse. You must avoid doing some heavy activities almost immediately. You can get back to your daily activities almost immediately. So these are the things to keep in mind. The next question that we're coming to is, what is the success rate of getting pregnant after hysteroscopy? That's a very important question because everybody wants to know. So what is the success rate? I think I've already spoken about it, but I will reinforce that the success rate of getting pregnant, that is the conception rate after performing a hysteroscopy, can be as high as about 40 to 80% after 1 year. So that is the success rate of a hysteroscopy. That is quite high. So, is hysteroscopy recommended before IVF or IUI treatment? As of today, not always. But if there are recurrent failures and if on ultrasound we don't get the optimum vision that we would like to, then yes, or in a woman who is aging, the time is running off, then these are the reasons why you must get a hysteroscopy pre-IVF to make sure that the uterus is ready or it is normal before you go for an IVF pregnancy. Are there any risk or side effects of hysteroscopy while treating for infertility? That's another very interesting point. So, well, the side effects are minimum as far as outpatient hysteroscopy or in-office hysteroscopy is concerned, because the complication rate is much less than 1%, around 0.02%. The only thing that can happen over here sometimes is bleeding, which is very minimum. We control it almost, and it is self-controlled almost immediately. Pain is one of the other reasons why you can have during in-office hysteroscopy, and vasovagal syncope, that is a syncopal attack, and that also can happen while performing a hysteroscopy, which is extremely rare to, as again about just about 0.5% or 0.7%. So these are very rare complications. Office hysteroscopy is very, very safe. Inpatient hysteroscopy is also safe, but the complication rates are slightly higher than office hysteroscopy. But even then, if it's been performed by an experienced surgeon, which should be performed by an experienced surgeon, the complication rates are as low as 1 to 2%. The complications that can occur while performing operative under anesthesia hysteroscopy can be again bleeding, a perforation, that is a hole through your uterus, which can be managed conservatively. How soon after a hysteroscopy can I try to conceive? So, what is the time limit? Well, it really depends on the pathology. There is one pathology I haven't spoken about, which is intrauterine adhesions, which I will address again after this. So, when you're performing a fibroid, if I remove a fibroid which is large, and the technique of removing the fibroid, sometimes we say to wait up to 4 weeks or sometimes 3 months. The next is polyps. Just about next cycle, more or less, we say start planning for pregnancy. Now, if you're trying naturally, almost immediately with the polyp, you can try. If you conceive, well and good. With the fibroid, we say wait at least for 4 weeks to up to 3 months. A septum, again, advice is to wait for 4 weeks or up to 3 months. And the other subtle lesions, one cycle, that is 4 weeks, should be sufficient many a times, after which you can start planning for pregnancy. Then I want to address something called Asherman's synechia or intrauterine synechia. So Asherman's is a condition where if you've had a normal vaginal delivery or a cesarean, or if you've undergone an abortion, a dilatation and curettage, sometimes inside your uterus there are very severe adhesions. That means the whole area, that is the uterine cavity, can be completely blocked. Once the uterine cavity is completely blocked, you will not bleed, or you will have minimum bleeding, or you may have normal bleeding, but you will not conceive. And that is one of the reasons which is sometimes diagnosed on ultrasound, sometimes it is not picked up on ultrasound. So secondary amenorrhea is called Asherman's. That is without a period, absolutely no period after you've had a normal birth, a cesarean, or a DNC. So that has to be addressed surgically. Now the success rate is unsure. It's a little lower compared to other conditions, and you may need repeat hysteroscopies, and it has to be performed by an expert. There are other causes of intrauterine adhesions, and that in our country, very common is tuberculosis. Almost about 2 to 4% tuberculosis is the cause of intrauterine adhesions. So it requires treatment and sometimes long-term treatment. We follow you up and we'll again have to possibly do a repeat hysteroscopy. So these are the conditions where hysteroscopy plays a very important role while for infertile women. Can hysteroscopy cause problem to get pregnant? No, hysteroscopy is actually useful for pregnancy. So it does not prevent you from getting pregnant. And hysteroscopy is only performed when indicated. So there are sometimes conditions where a blind endometrial biopsy is taken. Now the difference between performing a hysteroscopy and a blind biopsy is that blind biopsy is blind. That is, you don't see what's happening inside the uterus. Whereas while performing a hysteroscopy, you can see what is happening inside the uterus and you can treat it. And also the endometrial tissue that is obtained or the biopsy that we get is from all the places or places that appear abnormal. So definitely hysteroscopy is much superior. So with these questions, and I would like to say thank you to all of you for listening to me, and I hope I've addressed your concerns. And I would say if you want some more questions to be answered, or if you want any particular topics that you would want me to address, you can go on the website Advance Gynecology Center Care at Tanvir Hospital, and you can write in your comments, you can give us suggestions, and we will come up with more information. And the website will also have more information. Thank you.